results that we get. So as a rule of thumb, X-linked diseases, X-linked retinitis pigmentosa is the worst of all. That has a worse prognosis, followed by the autosomal recessive inheritance. Again, generally, autosomal dominant diseases tend to do much better than others. In terms of the actual mutations, nonsense mutations are generally more severe. I'll just show you an example of what that actually is. So in terms of macular dystrophies itself, some of them actually tend to do well in terms of, like achromatopsia, it's a stationary disease. Youngsters presented with pattern dystrophy, not too bad. Juvenile retinoschisis, as long as they don't have bleeds or a retinal detachment, they're not too bad. Best, of course, autosomal dominant is, definitely okay. Early onset Stargardt, like I said, is probably quite a severe disease. I'll just take a few seconds. So what does a nonsense mutation mean? So when you look at a mutation like this, here the arginine amino acid here has been terminated. So when a change in the amino acid creates a stop codon, there is no formation of the protein from that point, so it's called a nonsense mutation. That's much worse than what you would see, for example, so for example, in, something like, sorry, I don't have an example of that. Okay, so if there is just a change in the codon with, there's no stop codon being initiated, that's called a missense mutation. So they tend to do much better than nonsense mutations. So there are very specific mutations, for example, in Stargardt that actually have a better prognosis. So a lot of information is available about this, genetic mutations today. So what is the take home? Diagnosis, phenotype is the key to interpret the genotype. Prognosis, of course, multifactorial, and clinicians have a very, very keen role to play. Thank you so much.
Thank you, Dr. Rajani. Uni's request was that the discussion should happen at the end for the next 3 talks. I'll now invite George MANAYATH from Aravind Eye Hospital, Coimbatore, excellent in retinal imaging, to speak to us on predicting treatment response in DME and other vascular retinopathies.
Thank you, Uni, and let's look at predicting treatment response in diabetic macular edema. I would be looking at non-invasive imaging biomarkers, mainly the OCT and OCT angiographic predictors of vision. So the OCT biomarkers, the first one would be a central subfield thickness. And this is a central 1 millimeter zone of the OCT map of the macula. And it has been already shown that increased baseline CST on OCT has decreased visual acuity as a predictor. But even the decrease of central subfield thickness from the baseline with anti-VEGF therapy is also shown in multiple studies that it's at the baseline, as well as a reduction is a response to anti-VEGF and predictive of good vision. But the problem is multiple major studies like Protocol A with focal laser for the macular edema, at most there is a modest correlation between vision and baseline CST. And even in the change in vision and change in CST is with focal laser has been modest. Even the eyes with thick maculas has good vision and vice versa. So there is a paradoxical visual acuity outcome. So OCT measurement of the central subfield thickness may not be a good surrogate for visual outcome in DME management. Even Protocol T with anti-VEGF therapy showed that there is at best a moderate correlation between vision changes and changes in subfield thickness with anti-VEGF therapy. So is the thickness of the macula predict the visual outcome? No. CST is useful anatomical surrogate for diagnosing and monitoring DME, but it's not an accurate predictor of visual outcome. So then we have the OCT subtypes of DME like diffuse retinal thickening, cystoid edema, the serous macular detachment, and tractional DME. And few studies have shown that the large cystoid type of edema has worse vision than the other OCT subtypes. When we are talking about cystoid type of edema, it's not just the presence of cyst, the number of cysts, size, and their location. For example, large outer nuclear layer cyst more than 200 microns has negative impact on the retinal sensitivity. And most importantly, it is the residual tissue at the fovea, like this, as you can see, the bridging retinal process where the Mueller cells and the bipolar cells connect the outer retina to the inner retina, and the transmission of visual impulses that is most important in cystoid macular edema subtype of DME on OCT. So the bridging process is a positive predictor of vision outcome, and the serous macular detachment subtype where the external limiting membrane is disrupted in these cases, it has a favorable vision outcome if this is present at the baseline when we start the treatment of DME. And since there is an inflammatory theory with serous macular detachment and hyperreflective foci, DEX implant has been shown to be more effective than anti-VEGF therapy. So when we look at this subtype of DME and on OCT and the visual prediction, there is no consistent data that any morphological subtype has a significant prediction on visual outcomes in general. So coming to another predictor, that is hyperreflective foci, which are less than 30 microns. These are precursors of hard exudates at the fovea. These are lipoprotein extravasations because of the inflammatory process involved in the inner blood retinal barrier. There is activated microglia, and these multiple hyperreflective foci is associated with severe DME as well as poor vision with anti-VEGF therapy. And even in this setting, this biomarker, steroids have been shown to be much better in visual outcome compared to anti-VEGF therapy. So when you have multiple hyperreflective foci in the outer retina, there is an ELM disruption that is present along with in most of the cases. So another biomarker is hyperreflective foci in the choroid in DME, and this has been a poor prognostic marker because it's associated with severe forms of diabetic retinopathy like proliferative diabetic retinopathy. Again, a poor predictor in the management of diabetic macular edema. Coming to drill or the disorganization of the inner retinal layers, it is on OCT, the horizontal extent in microns of where the loss of boundaries of the inner retinal layers are lost. How to find a drill is track these inner retinal lines to the foveal center, and if there is loss of boundaries, this is how you find the drill within an OCT of DME. And the destruction of the bipolar amacrine and horizontal cells which transmit the impulses again from the outer retina to the ganglion cell layer is disrupted in drill. And the centrally located drill, that is if it involves more than 50% of the central 1 millimeter zone, then poor visual outcome can be predicted. And also the drill change. That is, if the extent of the drill changes by around 300 microns in the central 1 millimeter, if there is an increase in drill, you can expect a drop in vision over the next 8 months in such situations. So change in drill extent would be a robust predictive biomarker for visual outcome, more robust than the other changes on SD-OCT parameters. So for further therapeutic trial for treatment of DME, this would be a good marker rather than central subfield thickness alone as a biomarker. And this line or external limiting over the photoreceptor line, this where the Muller cells plexus with photoreceptors, and when there is a disruption of ELM, fluid comes into the outer retina and subretinal space, and this disruption of the external limiting membrane is a good prognostic. It is associated with less vision outcome and a good prognostic marker to predict the outcome in DME. Also the ellipsoid zone, this layer of ellipsoid zone above the RPE, this is a macular photoreceptor inner outer segment junction. So the percentage disruption of ellipsoid zone helps the clinician more accurately to predict the visual outcome when you start the treatment with diabetic macular edema. So it is shown that ELM disruption happens before the ellipsoid zone disruption. So the grading is grade 0 with no disruption, and grade 1 only ELM, and then grade 2 along with EZ disruption. So this correlate well with the logMAR visual acuity outcomes. So coming to the choroidal biomarkers, we know that the DME is generally associated with thinner choroid, but if you have a DME with greater baseline choroidal thickness, then you expect better anatomical and functional response to anti-VEGF therapy, because the intact choriocapillaries in thick choroid is associated with less outer retinal ischemia. So that is about the choroidal biomarkers. And parallelism, these subfoveal photoreceptors are skeletonized and segmented into linear lines of segmented lines. And in DME, there is a loss of parallelism here. This loss of parallelism is correlated strongly with poor visual acuity outcome in DME. So a recent biomarker that is added to predict the diabetic macular edema outcome is the ICHRM, which is the presence of this material in the intraretinal cystic spaces. And this composite material takes around 6 to 7 months to form after the onset of DME. So ICHRM is a poor predictive marker in DME management, because it has been shown that the visual acuity in patients with ICHRM is poorer than eyes without ICHRM, and they require more number of intravitreal injections, whether it be anti-VEGF or steroid injection. So it's a poor biomarker in DME outcome. And last bit about the taut posterior hyaloid phase is associated with recalcitrant diabetic macular edema with anti-VEGF therapy and requires vitrectomy as a treatment option. And coming to touch upon OCT angiographic biomarkers, it is seen that the size of the FAZ enlargement, this happens first in the deep capillary plexus and then in the superficial capillary plexus. So if there is only FAZ enlargement in the deep capillary plexus, and then a good response to anti-VEGF therapy can be expected. And this FAZ size can be quantitatively measured, unlike dye-based angiographies, and a larger FAZ has been shown to correlate with the presence of drill on the OCT-B scan. And also the vessel density, capillary vessel density loss is also another sensitive marker for hypoperfusion, and it affects both superficial and deep plexus. And intercapillary spacing also is a more sensitive parameter for foveal hypoperfusion than FAZ size and vessel density. And this fractal dimensions, where it is the geometric arrangements of the capillaries at the fovea, is reduced in DME, as you can see on the right side, and the reduction in fractal dimension happens both in superficial and deep capillary plexus in DME. So to compare fluorescein angiography and OCTA, we can advantage is that layer by layer we can study these parameters of FAZ size, vessel density, and intercapillary spacing, and this choice in pregnant and renal patients with DME. So to sum up, the negative biomarkers that we discussed, the increased central subfoveal thickness, the presence of drill, the large cyst in the outer nuclear layer, ELM and EZ disruption, hyperreflective foci in retina and choroid, and taut posterior hyaloid. So we expect a good visual outcome when there is a baseline serous macular detachment type of subtype, OCT subtypes, intact ellipsoid and ELM zone, the bridging retinal processes, absence of hyperreflective foci. And also increased subfoveal choroidal thickness is also a good biomarker for outcome with diabetic macular edema. So OCT and OCT biomarkers not only help us to grade the severity of the disease, modify our treatment plan, and also help us to predict the visual outcome in DME treatment. So thank you for your kind attention.